All right. So, good evening, everyone. I'm Dr. Soysa. I'm a senior registrar in internal medicine, and today I'm going to talk to you about acute coronary syndrome. So, acute coronary syndrome is a very, very important topic when it comes to ERPM because you're going to be asked a lot of questions on this for your theory in your MCQs as well as your SBAs. And also when it comes to clinicals, it's going to be a very important topic as well, because it has been one of the most commonest tested topics for the long cases also. In addition to that, once you get through this exam and once you become interns here in Sri Lanka or elsewhere, you would have to deal with these patients on a daily basis. So it's sort of impossible to work in any medical ward unless you can manage an acute coronary syndrome properly. So it's a very, very important topic to know. So I'm going to be running through the key concepts about acute coronary syndrome because I think it's important to understand the core concepts first. So, I mean, when it comes to ERPM, I know a lot of you are worried about it. I was a ERPM student as well. So back in 2018, I sat for my ERPM, and I was in the same place that you guys were, worried about the exam, a lot of pressure. There's a lot of stigma surrounding it. But I mean, you don't have to worry. You can take my word for it. If you actually have a consistent sort of a preparation, I mean, you don't have to sort of kill yourself over it. If you consistently study and go through the key concepts and then go through the papers and study around the questions, you should be fine. And it's actually an easy exam to get through. So don't worry too much about it, because a lot of people are going to tell you that it's very difficult, it's very difficult to pass, those sort of things. Those are usually excuses made by people. So it's a easy exam. So so let me go through the concepts, the key concepts of acute coronary syndrome, and then in that I'll be doing for the next 1.5 hours. And then in the last half an hour, we'll discuss some questions and we'll study around the questions as well, which is, I think, very important from an exam point of view. So let me share the screen. All right, so I hope that you can see my screen. So today's topic is acute coronary syndrome. So basically, I'll be going through these things. So I'll be talking about the definitions of acute coronary syndromes. I'll be talking shortly about the pathophysiology because it's quite important to understand what really happens in a person during an acute coronary syndrome, because then you can easily figure out the clinical features, the investigations, and the management. So any disease that you study about, always pay attention to the pathophysiology. Then I'll be talking about the clinical features that these patients present to us with. I'll be going through the ECG changes, which is very, very important, particularly once you start practicing and for the exams as well. The various cardiac markers that are involved, how to confirm your diagnosis with the imaging facilities that are available. And of course, the most important part of today's lecture is going to be about the management of an acute coronary syndrome. So that is usually the area that you are going to be mostly tested on. And also clinically, that is going to be a very important part of this topic. So fine, so let's get into it. So now when we say acute coronary syndrome, it's a syndrome. So it's not just one condition. So it's a whole spectrum of conditions. So, I mean, when you say something like dengue, now dengue is it's an infection. Influenza, it's an infection. So you're talking about a single disease. Now, acute coronary syndrome, the first thing to understand is that it's a spectrum of conditions. So there are so many different conditions that come under acute coronary syndrome. And the hallmark of all of these conditions is that they all cause myocardial ischemia and infarction. So don't worry, I'll be talking about each of these terms in detail as I go into the pathophysiology. But what you need to remember is that all these conditions share the same pathophysiology. So there's myocardial ischemia and myocardial infarction. So in other words, there's going to be reduced blood supply to your heart, and there's going to be damage to your heart muscles due to the lack of blood. So this can happen due to three main conditions. So that is ST elevation myocardial infarction or STEMI, non-ST elevation myocardial infarction or non-STEMI, and of course unstable angina. Now, it's important that we differentiate between these three as well, because the management is slightly different when it comes to these three. So they have some common ways of management as well. So there are parts of the management that are quite common for all these three conditions also. But there are some specific differences as well. So let's talk about them in detail. So now, how do we define acute coronary syndrome? So for there to be myocardial infarction, right? For there to be a myocardial infarction, there should be evidence of myocardial injury. So basically, to make that diagnosis, you should have evidence to say that there's myocardial injury or that there's damage to the myocardium. So damage to the myocardium is suggested by presence of elevated cardiac biomarkers. So I'll be talking about the various cardiac biomarkers in detail. So cardiac biomarkers, they're basically chemical substances that are released into your blood when your heart gets damaged. So every time your heart gets damaged, there's going to be release of these biomarkers into the bloodstream. And we can actually detect the levels of these cardiac biomarkers in the blood. So if the levels of these cardiac biomarkers are elevated, that would indirectly tell us that the heart is sort of getting damaged. So there are various types of cardiac biomarkers available, which I will talk in detail. But the important one for us from a clinical point of view is troponin. So there will be a rise in troponin due to the myocardial injury. And when we say a rise in troponin, now the troponin will come as a value. It might be 0.1, 0.2. So we need to define how high that is. So it should be more than 99th percentile of the normal population. So what that means is if you measure the troponin level in you and I, we will also get a value of troponin, but none of us are having acute coronary syndrome, hopefully at the moment. So that should be a normal one. So when you take the normal population, it should be more than the normal population. But that is not enough for you to diagnose acute coronary syndrome, because cardiac biomarkers would be elevated in any sort of a myocardial injury. So myocardial injuries can occur due to various different types of reasons. So it can occur due to acute coronary syndrome, which is one of the commonest causes. It can happen due to infections of the myocardium as well, or myocarditis. It can happen due to trauma to the myocardium. So there are so many different reasons why your troponin can go up. So in addition to having a high cardiac biomarker, or in addition to having a high level of troponin, you should also have other features to support your diagnosis of acute coronary syndrome. So these can be symptoms of myocardial ischemia. So that would essentially mean an ischemic type of a chest pain. So I'll talk about what's the exact definition of a ischemic type of chest pain. Then there should be ECG changes. So again, I'll be going into detail subsequently. And the imaging should show that there is loss of the viable myocardium. So there should be imaging evidence to show that there's damage to the myocardium. Or you should be able to do an angiogram and show that there's an occlusion of the blood vessels. So basically, in addition to having evidence that there is a myocardial injury, that there's myocardial damage, which is shown by the high troponin, you need to have at least one of these definitions, one of these criteria being fulfilled. So either symptoms of myocardial ischemia, which is a basic something that you elicit in the history, or you can do the ECG, which might show some changes. You might do some imaging, such as an echocardiogram or other advanced imaging, or you might do a coronary angiogram and you might visualize the clot. So remember, this is the latest definition of myocardial infarction. So there has been some older definitions in the past, but this is straight out of the European Society of Cardiology guidelines, which are the guidelines that are used by the cardiologists in Sri Lanka and referred by them. So this is the definition that you should know when you're defining acute coronary syndrome. So there are various components, and throughout the lecture, I'll be talking about how to sort of evaluate each of these different components. All right, so this is again a concept that is sometimes sort of poorly understood or poorly known by medical professionals. That is that there are different types of myocardial infarctions. Now, when we tell the word myocardial infarction, the obvious thing that comes to our mind is basically a clot or a thrombus going and blocking the blood vessels, right? So a clot going and blocking the blood vessels. And as a result, there's going to be a cutoff of the blood supply to the heart. So that is what essentially comes to our mind when we think about a myocardial infarction. However, there are some other types of myocardial infarctions as well. So the typical type of myocardial infarctions that we all know about, and the most commonly type of myocardial infarction that you would encounter as well as be tested on in your exams, is the type 1 myocardial infarction. So type 1 myocardial infarction is something like this, where you have sort of a clot, which is the first picture shown right on top, where you have a clot or a thrombus going and blocking the blood vessels, cutting off the blood supply to the heart. So that is the main type. But there are 4 other types as well. So type 2. Now, when you talk about a cutoff of the blood supply to the heart, we have to realize that there's a concept called the supply and demand. So our myocardium or our heart muscles require a certain amount of oxygen or blood to be delivered to it. So it requires some oxygen, some sugar, and other nutrients coming from the blood. So that is called the demand. Now the demand of the heart is not static. So it's not that the heart needs 50 ml of blood per minute every minute for the rest of your day. It's not like that. It will change. So when you're sleeping, when you're inactive, when you're bored during a lecture, the demand is going to be quite low. But on the other hand, let's say you're running, you're doing exercise or something like that, then the demand is higher. So the demand of the cardiac muscle or the demand of the heart can also change. This should be met by the supply. Now, the supply is basically your blood supply to the heart. So sometimes you can get a mismatch between your supply and the demand. So the mismatch between the supply and the demand can be either due to a high demand or it can be due to a low supply. Both a high demand and a low supply can cause this supply-demand mismatch, and this supply-demand mismatch can cause something called a type 2 myocardial infarction. So it can be due to conditions where the supply is low. For example, things like anemia, which is basically a condition where the hemoglobin in your blood is low. So less amount of oxygen will be delivered to the tissues, including your heart muscles. So in these patients, your blood vessels are nice and patent. Your blood vessels are not blocked, but there's still not enough oxygen going into your heart. So that is anemia. Another such condition is hypoxemia. So hypoxemia is when you basically have low levels of oxygen in your body. That can be due to various causes such as pneumonias or respiratory tract infections, asthma. So again, although you have a patent blood vessels, less oxygen is basically flowing to your heart muscles. Again, when you have a low blood pressure, so low blood pressure would also cut off the blood supply to your heart muscles. So in type 2 MI, the important concept is that they have nicely working patent blood vessels, but still there's not enough nutrition being supplied to the heart. So that is the second type of myocardial infarction. This is also quite common in clinical practice. You get a lot of patients with anemia, patients with CKD who have very low hemoglobin, who come to you with a typical picture of a myocardial infarction. So why am I spending time talking about this? Because it's important to realize that the management of a type 2 MI is good. All right, sorry about that. So, so type 4 myocardial infarction is a very interesting sort of a myocardial infarction. This occurs with percutaneous interventions. All right. So when a patient has a myocardial infarction or obstructive coronary disease, they will undergo something called an angiogram. I think angiogram is something that you all have heard of. Now, during the angiogram, if we go and identify a block, we can actually go and put a stent to unblock that vessel. So I'll be talking about that in detail. Don't worry about it. So that is called a percutaneous coronary intervention. Now, certain patients following a percutaneous intervention. So let's say you get a patient coming to you with a heart attack or a myocardial infarction, and then you send the patient for an angiogram. You realize that there is a block, and then you put in a stent. So the patient has undergone a percutaneous intervention. Now, following the percutaneous intervention, the patient can still get a myocardial infarction. So if a patient gets a myocardial infarction after stenting, that is called type 4 myocardial infarction. So that is further divided into 3 groups, 4A, 4B, and 4C. 4A occurs during the procedure. 4B occurs some time later because the stent gets blocked because of a blood clot forming inside the stent, or type C because of the stenosis of the stent. So any sort of a myocardial infarction occurring in a patient who has already undergone stenting is a type 4 myocardial infarction. And then lastly, we have type 5 myocardial infarction, which is myocardial infarction that occurs in patients who have undergone coronary artery bypass graft. So one other way of treating myocardial infarction, other than this percutaneous intervention or stenting, is to basically put a graft that will bypass the block. So those grafts can get blocked as well. So that is again a type of myocardial infarction. So you should know about type 1 myocardial infarction in detail. That is definitely the most important one to know about, but also have an idea about type 2, 3, 4, and 5 as well, because they are also quite important. So next, let's talk about the pathophysiology of myocardial. Let's talk about the pathophysiology of myocardial infarction in brief. So this is important to know because if you properly understand the pathophysiology of myocardial infarction, you can easily figure out the clinical features, the ECG changes, the investigation findings, as well as the treatment. So now, what is shown at the bottom of this picture is a blood vessel. Now, in this blood vessel, if you look at the lumen, so what you see here, I hope you can see my cursor. So what you can see here is the lumen, all right? So now the lumen is lined by a group of cells called endothelial cells. Now, endothelial cells are very, very important because endothelial cells will line the blood vessels from the inside. So your blood is in direct contact with your endothelial cells. Now the endothelial cells have to form a very smooth sort of a lining so that there can be very streamlined flow. So you can think about your blood vessels as some pipes. I mean, all of you must have seen pipes, right? Hopefully. So pipes will carry water around your house. Or if you use a pipe to sort of water the garden, you can see that the water flows through that pipe very smoothly. So one of the reasons that it flows smoothly is because the lining inside the pipe is very smooth. So similarly, you also have blood vessels which are obviously having a much more important role to play, that is to carry the blood around the body. And those blood vessels are lined by this endothelium. So as long as your endothelium is functioning well, as long as your endothelium is smooth, your blood can easily and smoothly flow through your blood vessels. So that is very, very important for the smooth flow of the blood vessels. But in certain patients, what happens is you can get an endothelial dysfunction. So what happens in these patients is that there's damage to your endothelium. So damage to the endothelium can occur due to many different reasons. So one of the reasons is that it might be due to high blood pressure. So when you have high blood pressure, you are having a system that is always pressing on and sort of compressing on your, sorry. Yeah, so when you have hypertension, you are having a system that is sort of always damaging your endothelial lining. So high blood pressure is one of the common reasons why your endothelial can get damaged. And probably the commonest reason worldwide is diabetes. So I'm not going to go into the pathophysiology of how diabetes causes endothelial dysfunction, It's a bit complex, but what you need to understand is high sugar in the body can again cause damage to endothelium. Smoking. So smoking is probably one of the most harmful things that you can do to your body, because cigarette smoke contains a lot of harmful substances such as nicotine, carbon monoxide, and tar, which can all damage your endothelium. And of course, the high cholesterol in your body. So your high levels of lipids. So all of these are going to damage this endothelium. So that smooth endothelium that you had is now damaged. So you have a rough surface. So when you have a rough surface, what's going to happen is, with this endothelial dysfunction, there's going to be accumulation of lipids. So what's going to happen is fat and lipid is going to accumulate below this endothelium. So your endothelium should look something like this, like the row right on top. But as a result of the dysfunction, it's going to look something like this, the one in the bottom. So a lot of lipids being collected. And as the lipids start collecting, there's going to be infiltration by a large number of inflammatory cells, including foam cells. Foam cells are basically lipid-laden macrophages. Then there's going to be infiltration by other macrophages, neutrophils, lymphocytes, and there's going to be a huge sort of an inflammatory process that goes on. So what's going to happen is this inflammatory process is going to sort of deposit more and more fat, more and more lipid. So you're going to get a lot of lipid being collected here, and you're going to get something called a plaque. Now, a plaque is basically a block in your blood vessels. So this plaque is going to narrow the lumen. Now, if you look at the left side of this blood vessel, you can see that the lumen is nice and patent. So there's a nice big lumen allowing your blood to nicely flow through it. But what happens when you have a plaque? When you have a plaque on the blood vessel, the plaque is going to go on compressing the lumen. So that nice lumen is now going to get constricted. So the blood can't smoothly flow through it. So there's going to be a block. So if you look to the right of the diagram, that is what has happened. So there has been a block in the blood vessel due to the deposition of the lipids. All right. So along with this inflammatory process, along with the deposition of the lipids and the inflammatory cells, there's going to be migration of smooth muscles as well. So the smooth muscles are going to migrate, and there's going to be fibrous tissue formation also. So you're going to have a lipid core, your plaque. Now we are talking about the block that is outside your blood vessel, or in the blood vessel wall rather. So now this plaque that is consisting of lipid, it's going to get coated by your smooth muscles and your fibrous tissue. So you're going to get a lipid core in the plaque, which is stabilized by a fibrous capsule. So that is the basis of this atherosclerotic plaque formation. So it is very important to realize this pathophysiology, because just having a plaque is not going to cause a STEMI or a severe myocardial infarction. Because what happens is, initially, this plaque is going to be quite small, and you're going to have a very nice, thick, fibrous capsule that is protecting. But if this patient continues to smoke, continues to have high blood pressure, continues to have poorly controlled diabetes, then what's going to happen is that the plaque is going to get more and more damaged. So as the plaque gets more and more damaged, the plaque will get bigger, the lipid core will get bigger, and this fibrous capsule will get weaker. So now you have a very weak covering to a big lipid plaque. So those sort of plaques are the dangerous ones, and those are the ones that can rupture and cause blocking of your blood system. So this is what happens. This is what you call plaque instability, where over time the plaques become more vulnerable because the lipid core becomes bigger and bigger, and your protective fibrous cap becomes smaller and smaller. So the end result of this is that there's going to be plaque rupture or erosion. I mean, think about the plaque getting bigger, 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 and this fibrous capsule getting weaker. At one point, it's just going to rupture. Now, what happens when it ruptures? Now, when it ruptures, all that material that was inside that plaque, so that plaque was nicely protected by the fibrous capsule. But now when it ruptures, all the material that is inside is going to get exposed to your blood. So all your collagen, all your tissue factors, and all that is going to get exposed to your blood. And these are thrombogenic material. So this is going to lead to thrombosis. Now, when we talk about thrombosis, there's an important triad called the Virchow's triad. You might have heard about this before when you studied about hematology. So when we talk about blood clotting inside the body, it requires three main things for the virtuous triad. So one is the hypercoagulability, that is a tendency of the blood to clot, activation of these clotting pathways, irregular blood flow, right? So irregular blood flow is something that leads to the uh, clotting inside the body and the endothelial dysfunctions. So here you have an endothelial dysfunction, you have irregular blood flow because now your lumen is pushed in by the plaque, and now you have exposure to thrombogenic material. So what's going to happen is there's going to be a thrombus formation, or there's going to be a clot formation within the blood vessel. So some people think that when you talk about myocardial infarction, it's just the plaque coming in and blocking the artery. No, it's not that. Plaque just come in, but then it's going to rupture, and then there's going to be a huge blood clot inside the blood vessel. So the moment you get a huge blood clot in the blood vessel, there's going to be a severe reduction in the blood supply to your myocardium. So that is what is going to cause myocardial infarction. So there are many steps in the thrombus formation as well. So this includes platelet activation and aggregation. So as you know, platelets are important blood components in your body that helps to form a clot to prevent bleeding. So when this sort of occurs within your blood vessels, it's going to form a thrombus that is going to occlude your blood vessels. So that is one of the early steps that occur. So as the platelets aggregate, there will be more and more other material that comes in, more and more other material that forms around the clot. And finally, you're going to get a thrombus formation. So this thrombus is going to basically occlude your coronary artery. So your coronary artery, which was nice and patent before, is now blocked by this thrombus. So if you look at the picture on the right, you can see this in the diagram. So here you can see that at the proximal end of the blood vessel, you had a nice, at the proximal end, you had a nice sort of a lumen. Then what happened? You got lipid getting deposited, you got a plaque formation. So the patient still didn't control the blood pressure, still smoked, still had poor sugar. So what happened? The plaque got unstable, and finally the plaque ruptured. So once the plaque ruptured, it led to a clot formation within the blood vessel. So what you see here is basically a clot that has formed within the blood vessels. So what happens when you get a clot? There's going to be a significant severe impairment of the blood flow. So there's no more blood flow through these blood vessels. And as a result, your myocardium or your heart muscles, your heart tissues are going to get lack of a blood supply, and they are going to undergo infarction. So if you get like a partial block, it can lead to something like unstable angina or non-ST elevation MI. But if it leads to a complete block, it will lead to the most severe type of acute coronary syndrome that you can get, and that is STEMI, that is ST elevation, myocardial infarction. So the reason I spend a lot of time on this pathophysiology is if you properly understand this, the rest of the lecture is going to be super simple to understand. So does anyone have any questions till now? Please feel free to ask any questions. So any questions in the pathophysiology? All right. So I mean, if you have any questions at any point during the lecture, you can always interrupt me and ask it, because it's very important to clear your doubts, because I mean, you are sacrificing 2 hours of your valuable time for this lecture. So I mean, make best use of it. All right. So what are the clinical features? So what has happened now? There's not enough blood flow to the heart. So what's going to happen? There's going to be necrosis of your heart muscles. There's going to be death of your heart cells. So what is that going to cause? It's going to cause pain. So the typical clinical feature of acute coronary syndrome is chest pain. But the thing is, you can't just say chest pain and keep quiet, because chest pain you can get due to a lot of reasons. I mean, I'm sure all of you have had some chest pain during your at some point during your life. So that doesn't mean that any of you have had acute coronary syndrome. So you can get it due to gastritis, you can get it due to pneumonias, you can get it due to a pulmonary embolism, due to a dissection, due to trauma to the chest. So we need to differentiate whether this chest pain is actually due to ischemia or whether this chest pain is actually due to an acute coronary syndrome. So for that, the chest pain should have a particular set of characteristic clinical features. So the typical set of characteristic clinical features are that it should typically be a retrosternal sort of a chest pain. So retrosternal is just to the left, just over your precordium or just to the left of your sternum. I hope everyone knows where the sternum is. So just to left of that would be your retrosternal area. So it's typically retrosternal and it's tightening or pressure. So what they say is, in Sinhala, they might say, "Papu thada karna," or there's pressure on the chest. It's a constricting, tightening chest pain. And usually the chest pain can radiate. So it will not just stick to your chest. From the chest, the pain can even go to your jaws, it can go to your left arm, or even to your right arm. So the typical chest pain is a retrosternal tightening sort of a chest pain that radiates to the jaw or the left arm. Having said that, in clinical practice, remember any pain that occurs between your jaw and your epigastric region can be acute coronary syndrome. So some patients present you even with a right-sided chest pain. Some people even present you with epigastric pain, pain over their tummy, not over their chest. So you can get a wide variation of these clinical features, particularly in diabetics and particularly in older patients, you can get atypical presentations, but it's important to know the typical presentation because you should recognize that first before thinking about atypical things. So remember, it will be tightening, retrosternal, radiating to the jaw or the left arm, but it can always radiate to the right arm as well. I mean, just because it radiates to the right arm, don't be like, no, this patient is not having acute coronary syndrome. It can occur, right? So in addition to that, the patient can have some associated other symptoms as well. So one important symptom is shortness of breath. I mean, your heart is the organ that pumps blood to the rest of your body. So the moment your heart is not working, the rest of the body is going to suffer. So the lungs will beg you for more oxygen because the rest of your body is not getting enough oxygen. So your lungs will start working harder. So there'll be shortness of breath. Because of the pain, because of the ischemia, you're going to get a lot of sweating. So diaphoresis. And you're going to get nausea, you feel vomitish, you might even vomit. And if the heart is not pumping enough blood, the blood supply to the brain can be cut off and you can even pass out. So you might get a syncope where you might even lose consciousness. Always know about atypical presentations as well. So atypical presentations, as I mentioned, are more common in elderly. It's more common in women. So I'm not being sexist, but when in practice also, it's sometimes you get all sort of weird pains in ladies, which turn out to be acute coronary syndrome. So and also in diabetics. So in elderly females and in diabetics, expect some atypical presentation. But for your exam point of view, for your long cases and for your theory, know the typical presentation. So now when you get a chest pain doesn't necessarily mean that you have an acute coronary syndrome. There's also an entity called chronic coronary syndrome. So you might be familiar with the term stable angina. So previously we used to label patients with chest pain into acute coronary syndrome and stable angina. However, we don't do that anymore. So the term stable angina, in the newer guidelines, it has been replaced by the term chronic coronary syndrome. So in chronic coronary syndrome, this chest pain occurs only on exertion. So only when the patient is doing some exercise, climbing stairs, or when the patient is emotionally stressed. And it relieves when the patient rests or when the patient takes some nitrates. But when you talk about acute coronary syndrome, the chest pain occurs even at rest. So it is not completely relieved by the rest or by nitrates. So now that is very, very important to understand. Because when you get a patient coming with chest pain, the only thing that you need to differentiate whether you are dealing with a typical sort of a chest pain, whether you are dealing with a chronic coronary syndrome or whether you are dealing with an acute coronary syndrome is the history. Because if you take a good enough history, you will know whether you are dealing with an acute coronary syndrome or a chronic coronary syndrome. You don't need any investigation, you don't need any ECGs, you don't need any blood test, you don't need any imaging, you don't need any angiogram. Just simply by talking to the patient, you should be able to differentiate acute from chronic coronary syndrome. So how do you differentiate? In chronic, the pain is only on exertion when they're active. It goes off when they rest or when they take nitrates. I'll talk to you about what nitrates are. While in acute coronary syndrome, the chest pain is going to persist even when they're at rest, and it's not going to be completely resolved by the nitrates or by rest. All right. But now, when you get a patient with chest pains, first thing, talk to the patient and establish whether you're dealing with an acute coronary syndrome. If you have established that you're dealing with an acute coronary syndrome, your next step is to differentiate which type of acute coronary syndrome you're dealing with. Because when it comes to acute coronary syndrome, again, you have three types, right? You have ST elevation myocardial infarction, you have non-ST elevation myocardial infarction, and also you have unstable angina. So how do you differentiate between these three types? So how you differentiate is you have to do an ECG. So as soon as the patient comes to you with a chest pain, get an ECG done. How early? Immediately. Not 10 minutes later, not 30 minutes later, not 1 hour later, immediately. Patient walks to you with a chest pain, you take the history, you measure the vitals, make sure the patient is stable, and immediately call the ECG technician to come and take the ECG. There should be no delay because we are talking about a very time critical condition here. The more time you waste, the more damage to the heart muscle, right? So there's going to be ischemia or there's going to be infarction to your cardiac tissues, right? So the more time you spend without restoring the blood supply, the more time your heart is going to be deficient of blood. And the more time the heart is deficient of blood, the more myocardial tissues that are going to get damaged, more amount of myocardial cells that are going to die. And when they die, you can't restore it. The moment they go into infarction, there's nothing that you can do about it. And the patient is going to get so many complications like heart failure, arrhythmias, and the rest of the life is going to be miserable. They are not going to be able to do anything else. They are going to be very tired. They might get bedridden, and they might even die because of heart failure. So the only way that you can avoid the heart failure is by protecting your cardiac muscle. So time is muscle. When it comes to acute coronary syndrome, you have to be fast. You have to be on your A game. You have to work fast. You have to get the rest of the team involved, and you have to act fast, and you have to treat fast. So you have to diagnose fast. You have to treat fast. The faster you treat, the more myocardial tissue you will preserve, and the more healthy your patient is going to be. The more time you waste, more myocardial death, more complications, and it's going to be bad for the patient. So do the ECG immediately. So when you get an ECG, the first thing that you look for is this ST elevation. So of these three pictures, focus on the one in the left. So that is a normal ECG. So you have this small bump, which is called the P wave. Then you have the upward spike, which is called the R wave. Downward spike, which is called the S wave. Then you have a flat segment here, which is called the ST segment. And then you have another wave here called the T wave. So P, R, S, T, and between the R, S and the T, the ST segment. So what happens in ST elevation MI? There's nothing to really know because ST elevation MI. So your ST segment gets elevated. Simple as that. So this ST segment was right at the baseline. But when it comes to a STEMI, ST elevation myocardial infarction, your ST segment has gone up. So this is a ST elevation myocardial infarction. So if you see an ST elevation in the ECG, that is a STEMI. Or it can be a left bundle branch block as well, which I'll be talking to you in the next slide. So if you see ST elevation or a new onset left bundle branch block, then you're dealing with a STEMI. But if you see other sort of ECG changes that are suggestive of ischemia, for example, this ST segment can go down. So if the ST segment goes down, that is called ST segment depression. This T wave should be nice and upright. Sometimes the T wave can go down. So if the T wave goes down, that is called ST segment depression. Or you might not get any T wave. That is called T wave flattening. So all other ECG changes of ischemia other than ST elevation or other than a left bundle branch block, which might include ST segment depression, T wave inversion, T wave flattening, all of this will suggest that the patient is having either an unstemi or an unstable angina. Unfortunately, you can't differentiate between these two conditions just from the ECG, but you can easily differentiate between STEMI and an unstemi unstable angina. That is crucial because that will help you to manage the patient, because the management is of these two types are quite different. Another important thing to remember is that these changes are dynamic. So what do you mean by dynamic? It means that these changes are constantly changing. So your myocardium is getting damaged. So the myocardium or the heart that the patient had 5 minutes back is not what he has now, because some of the tissues have got damaged. If you check 5 minutes later, he's going to have a completely different heart, because some more of his heart muscle have got destroyed. If you check his heart after 30 minutes, it's going to be way different to what it started with, because with time there's going to be progressive damage. So since your heart is progressively changing with time, your ECGs are also going to be constantly changing with time. So that is an important concept to understand. The fact that the ECGs are always changing. So initially you might get a ST depression, then you might get a T wave inversion. Initially you might get a T flattening, then you might get a T wave inversion. So these changes of the ECG is called a dynamic ECG. So ECGs that are dynamic are characteristic of an acute coronary syndrome. And another important concept is that initially when you take a ECG, that might be normal, because still the ECG changes have not occurred. But if you repeat the ECG in 10 minutes, you might see the changes. So remember, this is a very, very important thing to remember. In a patient coming with chest pain, just because one ECG is normal, that does not tell that the patient is normal. You have to always repeat the ECG. So you have to do serial ECGs, and you have to keep repeating the ECGs at least every 10 minutes. And in the repeat ECGs, look for the dynamic changes. So even if your initial ECGs are completely normal, if your repeat ECGs are showing changes, if they are dynamic, that means the patient is having acute coronary syndrome. So that is one of the most classical features of an acute coronary syndrome, the dynamic changes. All right. So depending on the location where you see the ECG changes, that can give you a clue as to which part of your heart is involved. Because your ECG, the different leads of your ECG are going to look at different parts of your heart. Now, if you look at the blood supply of the heart, there are mainly three blood vessels that are supplying it. So you have the right coronary artery, then you have the left main coronary artery, which divides into a left anterior descending artery and the left circumflex artery. So you have mainly three blood vessels. So the right coronary artery, and then the left anterior descending artery, and then the left circumflex artery. So the right coronary artery is basically supplying the inferior and the right side of your heart. The left anterior descending artery is going to be supplying the anterior part of the heart. And the left circumflex artery is going to be supplying the lateral part of your heart. So depending on which blood vessel gets blocked, different parts of the heart can undergo damage. So for example, if the right coronary artery is blocked, there will be damage to your inferior and the right side of your heart. If your left anterior descending artery is blocked, there will be damage to your anterior part of the heart. And if there's block of the left circumflex artery, there can be damage to the lateral part of your heart. So depending on where your ECG changes are, you can know which artery is blocked. So that is a very beautiful thing, because just by looking at the ECG, you can know which artery is blocked. So before going and doing an angiogram, you actually know which vessel is blocked. So it's important to know how to correlate the ECG changes to the blocked blood vessel. So basically, when you have ECG changes in V1 to V4, so you have various ECG leads when you take a ECG. So if you have changes or ST elevation in V1 to V4, that tells you that the anterior part of your heart is involved. So that means the left anterior descending artery is occluded. So ST elevations in V1 to V4, anterior wall of the myocardium is involved, and the artery is left anterior descending artery. You might get some non-specific reciprocal changes, such as ST depressions in the opposite side of the heart. So the moment you have an ST elevation in one part of the heart, the opposite part of the heart, there can be ST depressions. So when you get an anterior ST elevation in MI, you can get ST depressions in 2, 3, and 8. Similarly, if you get a ST elevation in 2-3 and AVF, that means the inferior part of your heart is involved, which means that the right coronary artery is involved. Now, when the right coronary artery is involved, it's not only the inferior part of the heart that is involved, the right ventricle can also be involved. So you might have to do some right-sided leads as well. So you should tell the ECG technician, okay, so you should be smart enough to know that, okay, I have seen an ST elevation in 2-3 and AVF. Okay, so the pathology is in the right coronary artery, but I know that right coronary artery will also supply the right side of the heart. So you will tell the ECG technician to put some right-sided leads as well, to put some extra leads to the right side of the patient's chest and look at the right ventricle as well. So when you look at the right-sided leads, which is V3R and V4R, you will see ST elevations in V3R and V4R if the right ventricle is involved. All right. So V1 to V4, anterior, left anterior descending. 2-3 AVF, inferior, which is the right coronary artery. Always look at the right ventricle as well. But if you get involvement of AVL, V5 and V6. So AVL, V5 and V6 are looking at the lateral part of the heart. So if you get a ST elevation in AVL, V5 and V6, that means it's the left circumflex artery that is involved. Again, the right coronary artery is a special one because in addition to inferior, it supplies the right ventricle and it supplies the posterior part of the heart as well. So every time you are suspecting a right coronary artery block, make sure that you look at the posterior part of the heart as well. So you might have to look at V7 to V9 also. So this is how you localize the culprit artery. So this is how you localize the blocked artery just simply by looking at the ECG. So again, V1 to V4, anterior STEMI, left anterior descending artery. 2-3 AVF, inferior STEMI, right coronary artery. Make sure that you look at the right ventricle and the posterior part of the heart as well. 1 AVL, V5 to V6, lateral STEMI, and you are looking at the left circumflex artery. So this is how you sort of know which vessel is occluded before you even go and do an angiogram. All right, so when it comes to STEMI, I also mentioned about something called a left bundle branch block. So what is a left bundle branch block? So left bundle branch block is basically when your V5 and V6. So when you look at the leads, V5 and V6, if it looks something like this. So when you see sort of an M pattern in your ECG. So when you look at the ECG V5 and V6, if you see this M pattern, or you can remember it as a rabbit ear. So if the ECG looks like the 2 ears of a rabbit, that is a left bundle branch block. If you get this in V1 and V2, that is a right bundle branch block. If you get it in V5 and V6, that is a left bundle branch block. So if you go back to the previous slide, I mentioned that STEMI is a ST segment elevation or a new onset LVP. So now how do you know whether this is new onset or not? So if you have seen this patient before and if you have an old ECG, which is normal and didn't have a left bundle branch block, and now you do an ECG and you see this, okay, then you know it's a new one. But what if it's a patient who comes for the first time? So if it's a patient who comes for the first time, you might have to look at some other things to see whether this is new onset or not. So that is called Garbosa's criteria. So it's not important for you to know all these steps. If you're interested, please go ahead and know these steps because it's important for your practice. But from an exam point of view, know that when you see a left bundle branch block, it has to be new onset to diagnose a STEMI. And how you diagnose whether it's new onset or not is by applying the Garbosa criteria. So Garbosa criteria means in a patient who has a positive QRS complex. So patients who have an upright QRS complex, if the ST elevation is more than 1 millimeter. Or in the patients who have a downward QRS complex, if the ST depression is more than 1 millimeter. Or in patients who have a downward QRS, if the ST elevation is more than 5 millimeters. So if you think that this is too complex, you can forget about it. But know that this is an important criteria which we use in clinical practice to differentiate whether the left bundle branch block is a new onset one or it's a long-standing old one. All right, so then comes the cardiac biomarkers. So every time you get a patient with chest pain, what's the first thing that you do? History, examine, stabilize, ECG. Not one ECG, serial ECGs to look for dynamic changes. Then what are you going to do? You're going to look at the cardiac biomarkers. So cardiac biomarkers, as I mentioned at the start of the lecture, they're usually chemical substances that are released into your bloodstream when your myocardium is getting damaged. So they're indirectly telling you that your myocardium is under damage. So previously there were so many different cardiac biomarkers that we used, including troponin I, CPK or creatine phosphokinase, myoglobin, LDH. So many different types of cardiac biomarkers. So those have sort of become redundant now because those are not good enough, because those are not very specific, because they can go up in a lot of other conditions as well. And one of the major barriers when we use these old cardiac biomarkers is because things like your normal conventional troponin I or your creatine phosphokinase or your LDH, AST, they take some time to rise. So it will take a few hours before they start rising. So if a patient immediately comes to you with chest pain, you have to tell the patient, okay, wait. We have to wait till those hours go, and then only we are going to send your blood for the cardiac biomarkers. So that is not really a very useful or a good test. So now it has been replaced by highly sensitive troponin I. Highly sensitive troponin I is available freely throughout Sri Lanka. So it's a widely available test, and that is what we use now. So the advantage of using a highly specific, highly sensitive troponin I is the fact that it's more specific. So it is more specific to myocardial damage. And also it immediately rises. So if the patient gets a myocardial infarction or a chest pain, it immediately goes up. So almost immediately your highly sensitive tropi will start rising. So if a patient comes to you immediately with a chest pain, you don't have to really wait. You can just immediately send the highly sensitive tropi. So that makes it a good advantage to use this. So why do we need this? So now let's say you get a patient who comes to you, you take the history, there's chest pain at rest. So it's acute coronary syndrome. Because if there's chest pain at rest, it has to be acute coronary syndrome. Chronic coronary syndrome, the chest pain should resolve with rest. So now you have excluded chronic coronary syndrome, you have made a diagnosis of acute coronary syndrome. Then you do the ECG. When do you do it? Immediately. How many times? Repeatedly. Then you do the ECG and then you look for the features of a STEMI. What are those? ST segment elevation or your rabbit tears, left bundle branch block. If that is there, you have diagnosed a STEMI. End of the story, you start treating the patient. But let's say you don't see a ST elevation or you don't see a new onset LVP. But you see some other ischemic changes such as ST segment depression, T wave inversion, T wave flattening, that sort of a thing. So if you see some other changes, it can either be a non-STEMI or it can be an unstable angina. Now, how do you differentiate between non-STEMI and unstable angina? So the only way to differentiate between these two is to look at the cardiac biomarkers. So if the cardiac biomarkers are elevated, if your troponin I or your highly sensitive troponin is elevated, that is a non-STEMI. If it is normal, it's unstable angina. So it's a very, very simple sort of an algorithm. So you can easily diagnose this, and it's a very simple thing, and it's something that you need to be very, very thorough with. So if there's no STEMI, do the cardiac biomarkers. If it's positive, it's a non-STEMI. If it's negative, it's unstable angina. So there is an algorithm that we use, an algorithm that has been designed by the European Society of Cardiology that tells us how to sort of interpret these findings. So let's quickly look into that. So when you get a patient who comes to you with chest pain, you have excluded chronic coronary syndrome, you have excluded acute, you have basically excluded a STEMI, and now you are thinking of a non-ST elevation, myocardial infarction, or unstable angina. So what do you do? So what you do is you send a highly sensitive troponin. If your highly sensitive troponin is low, again, you don't exclude non-STEMI. The reason for that is, I mean, as I mentioned before, your heart is changing, your myocardium is changing. So just like your ECG is changing, your cardiac markers are also changing. So although your initial troponin is negative, you might get a positive troponin later on. So even if your initial troponin is negative, you repeat the troponin after 1 hour. So if you repeat the troponin after 1 hour, and if that is positive, you still take it as a non-STEMI. So basically, patient comes to you send a troponin, it's negative. You repeat it in 1 hour, now it's positive. then it's a non-STEMI. You do it when the patient comes, it's negative. You repeat again in 1 hour, it's still negative. Then that's an unstable angina. So this diagram, that is basically what it says. It tells you, don't rely on a single value. Repeat after 1 hour and see. If both the starting and the repeat are negative, then only it's unstable angina. If either the start is negative or the repeat is negative, that means the start is negative, but the repeat is positive, then it's a non-STEMI. So that, so that is basically how you approach a patient. Take the history, exclude chronic coronary syndrome, take a ECG, exclude STEMI, do the highly sensitive top pipe, positive non-STEMI, negative unstable angina. So then, of course, we are going to get the help of some imaging. So one is an echocardiogram. So your echocardiogram would look something like this. It is basically you're going to put some gel on your chest and put an ultrasound probe, and then you can see the cardiac chamber. So it's very beautiful. You can see the cardiac chambers moving and contracting in real time. So when there is infarction or when there's damage to your myocardial tissue, the nicely contracting cardiac muscle will fail to, so it will not contract. One part, some parts of the myocardium will get contracted, other parts won't. For example, let's say you have ischemia to this part of your myocardium, this part of the myocardium won't move. So the myocardium that was moving like this, now this one is not going to move, only this is going to move. So there's going to be reduced motion in certain parts of the cardiac muscle. So this reduced motion in certain parts of the cardiac muscle can be seen in echo, and that is what we refer to as a regional wall motion abnormality. So the gold standard is, of course, to do an angiogram. So angiogram is basically we insert a catheter through your radial artery in your arm or through the femoral artery in the leg, and we pass some dye into it so that we can see the coronary vessels. So when we see the coronary vessels, we can easily see the blocks in the coronary vessels as well. So this is a coronary angiogram, and you can see the dye nicely flowing. You can see a few blocks here. So the moment you get a block, let's say you get a block here, then the dye will not move. Now in this patient, this vessel is nicely outlined by the dye in the coronary angiogram. But let's say you get a thrombus or a block here, the dye is only going to come till here. So the dye can't go beyond that block. So the dye will come only up till here, and this part will not get highlighted by the dye. Then you know that there is a block in the coronary vessels. So that is basically the gold standard way to diagnose a myocardial infarction. There are other new modalities that are available, including things like cardiac MRI, but those are not very important in the acute setting. In the acute setting, it's mainly your echocardiogram and your coronary angiogram. So how do you manage a patient with acute coronary syndrome? So the management of acute coronary syndrome should be familiar to you, because you can get this tested in your theory as well as in your emergencies as well. So, and as an HO, as an intern, you're going to be managing acute coronary syndromes day in and day out. Trust me, it's going to be probably the most common medical emergency that you're going to manage. So when a patient comes to you with acute coronary syndrome, now I spend a lot of time telling you how to differentiate between STEMI, non-STEMI, and unstable angina. But there are some managements that are common to all three. And of course, there are managements that are different to those three as well. So let's first talk about the management that is common for all three. So if it's an acute coronary syndrome, whether it's STEMI, whether it's non-STEMI, whether it's unstable angina, you can do these things. So those are, one is pain relief. I mean, if a patient comes to you screaming in pain, you can't obviously leave that patient in pain, right? So the first thing to do when you come across a patient with acute coronary syndrome is to manage the pain. So how are you going to manage the pain? So you can use nitrates. So nitrates are basically vasodilators, right? So when you have a blood vessel that has gone into spasm and blocked, you can give a nitrate so that it slightly dilates. Now you have a blood vessel that is completely blocked like this. But if the vessel dilates a bit, then you're giving a bit of a gap for the blood to flow, right? So you're giving I'm running out of hands. So you're basically, so when you dilate the vessel, you're basically giving some space for the blood to flow. So that will sort of increase the blood supply to your heart, and that will reduce the ischemia. And of course, when the ischemia reduces, the pain is also going to reduce. All right. So one way to manage the pain is to go for nitrates. So nitrates, the commonly used nitrates are sublingual nitrates such as sublingual nitroglycerin, which can be used for the relief of chest pain. However, nitrates can be dangerous also because when you give vasodilators, it can cause your blood pressure to suddenly drop. So that is something that you have to keep in mind. So when you're dealing with a patient with myocardial infarction, they might have low blood pressure. So if they have low blood pressure, think twice when you give nitrates because they can further reduce the blood pressure. When you have a right ventricular infarction, again, they are very sensitive to your preload. So preload is the amount of blood that returns back to your right ventricle. So when you give nitrates or vasodilators, the amount of blood that returns to your right ventricle is sort of reduced. So that can further impair the cardiac output. And of course, if you have recently used phosphodiesterase inhibitors, because if you've done that, it can further cause too much of vasodilation and it can cause a sudden drop in the blood pressure. So first thing is what? Pain management. How do you do it? With nitrates. But in certain patients, nitrates might not work. And if you actually listen to my what I've been saying in the past few minutes, I said that acute coronary syndrome by definition doesn't respond to nitrates as well, because chronic coronary syndrome is the one that relieves with nitrates. Acute coronary syndrome has very poor response to nitrates. There can be some response, of course, but it's not going to be a good enough response. All right. So when it comes to acute coronary syndrome, the nitrates might not be enough to control the pain. So for severe pain, you might have to go for beta analgesics. And the beta analgesic that we usually use is morphine. So morphine is a very strong analgesic. It's an opioid. So if the pain is not controlled by nitrates, you can go for morphine. Everything has some bad effects also. So morphine can delay the action of P2Y12 inhibitors, which are important drugs that we use in the management. So your clopidogrel, which all of you must have heard, is a P2Y12 inhibitor. So morphine can sort of delay the action of that as well. Oxygen. So now when you have a myocardial infarction, your heart is starving for oxygen, right? Because there's going to be a block. So you should not let the patient starve for oxygen. You should give the oxygen. However, we should not blindly give oxygen as well. So in the past, many decades back, when a patient presents with a myocardial infarction, they will be automatically put on a lot of oxygen. But later, they found that this can actually be harmful. The reason for this is when you give too much of oxygen, this oxygen can form particles called oxygen-free radicals. And these oxygen-free radicals can further harm your myocardium. So to prevent these oxygen-free radicals further harming your myocardium, we give oxygen only when it is actually necessary. So only when the saturation is less than 92%, that is when we give oxygen. So if the saturation is more than 92%, don't give oxygen because that can further cause myocardial damage through the free radicals. Then the other important thing is for every patient with an acute coronary syndrome, give them stat doses. So all of them should be given these three drugs. That is aspirin 300 milligrams, clopidogrel 300 milligrams, atorvastatin 40 to 80 milligrams. So you can even give this before doing the ECG, before you do the troponin. Why is that? Because you do the ECG and the troponin to separate between STEMI, non-STEMI, and unstable angina. To diagnose acute coronary syndrome, all you need to do is talk to the patient. So since this management is common to all three subtypes, even before doing the ECG, you can give these stat doses. So all patients with acute coronary syndrome should be given aspirin, clopidogrel, and atorvastatin. They will stabilize that plaque. So that plaque which is vulnerable and rupturing, it will get stabilized by these antiplatelets and by the statin. So that is an essential step in the management. All right. So after you give the step doses, aspirin 300, clopid 300, atorvastatin 300. Now from that point onwards, the rest of the management would depend on which type of acute coronary syndrome you are dealing with. Whether you are dealing with a STEMI, a non-STEMI, or an unstable angina. Now, if it is a STEMI, what we have to do is reperfuse the patient. So now the patient is having ischemic tissues. Patient is having myocardial tissues that are starving for some blood, that are starving for some oxygen. So what are we going to do? We have to restore the blood supply to those starving tissues. So how do we restore the blood supply? So there are different ways that we can restore the blood supply. Not many, there are mainly two ways that we can restore the blood supply. So one is by a percutaneous intervention. So percutaneous intervention is basically, now I talked to you about the angiogram, right? You pass a catheter, you pass some dye, and you visualize where the clot is. So through that same catheter, what you can do is you can put in a stent. Now stent is going to be something like a wire mesh. So now you have a block here, right? You have a block here. Now your blood vessels are blocked, right? So what you do is you pass this wire mesh or the stent into that blocked blood vessel like that, and then you open up the stent. So basically you have a very clogged up blood vessel like this, right? So you have a clogged up blocked blood vessel. So what are we doing? We are passing the stent into the clot or the block, and then the stent is going to open up. So the moment the stent opens up, the blood can flow through. It's very beautiful, right? So it's a simple concept to understand, but it's a difficult one to perform, of course. But that is the best way. So there's no doubt about it. There's enough evidence to tell you that percutaneous intervention by stenting is the best management of STEMI. So if you get a SBA asking about the best management of STEMI, it's PCI, percutaneous intervention. It's not any other option. Although it is the best option, one of the main problems when it comes to percutaneous interventions or when it comes to stenting is the fact that it is not widely available. So not every hospital that you work in would have this stent. So, if you take the Western province, NHSL has it, but Kaluboyle doesn't have it, Panudara doesn't have it, Kalutara has it again. So not every hospital has it. So if you're working in a hospital where you have these facilities, you should always go for a percutaneous intervention. But if you don't, now you have a choice. Are you going to transfer the patient to a center that has it, or are you going to do something in your center? For example, let's say you're working in Panadu, all right, and you get a patient coming with a STEMI. Are you going to transfer the patient to NHSL and get a stenting done, or are you going to manage the patient medically at Panadu? Now, the obvious answer to that question is to transfer and get a stenting done. But as I told you before, time is muscle. Every minute that you waste, there's going to be muscle that is going to be damaged. The time you take to do the ECG, the time you diagnose a STEMI and put the patient into the ambulance, minor staff comes, puts the patient into the trolley, puts the trolley into the ambulance. All that time, your cardiac muscle, the patient's cardiac muscle is getting damaged. Ambulance is going from Panadura, Moratua, Dehivala, cardiac muscle is continuously getting damaged. So every second, every minute, your cardiac muscle is getting damaged. Now your decision is, are you going to let some cardiac muscle get damaged and then do a stent, or are you not going to allow that to happen, and are you going to intervene with something not as good as stenting? So for that, we have some time cutoffs. Now, this is an important thing to understand. This is again commonly tested at your exams. So if you can transfer a patient within 120 minutes, that is within 2 hours. If you can transfer and do a PCI within 120 minutes, then you should go for the transfer. What that means is, from the time you diagnose the STEMI from the ECG to the time the angiogram is started, if you can have that in 2 hours. That is basically, let's say you're working in Pangura, patient comes to you with chest pain, you do an ECG, there's a STEMI. The clock starts ticking. Now you have to think, within the next 2 hours, can I transfer this patient to NHSL? Can I arrange the ambulance? Can the ambulance take the patient to NHSL? Are there beds available at NHSL? And whether they can do the angiogram in NHSL? Everything within that 120-minute time window. If you can do all of that, from the diagnosis to the angiogram, if you can do all of that within the 120 minutes, then you go for it. Then you go for the percutaneous intervention, because that is the best treatment available. But if it's taking more than 120 minutes, then don't go for it. Because then it's better to keep the patient at your center and medically treat the patient rather than risking more myocardium getting killed. So the time gap for you to take that decision is 120 minutes. So have that in mind, right? If you can transfer and do it in 120 minutes, by all means do it. But if it's going to take even 5 minutes longer than that, don't do it. All right. So our targets are, it should be done within 60 minutes of presentation in a PCI center. So if the patient presents to somewhere like NHSL, we should target the stenting to be done within 60 minutes. If it is a non-PCI center where you have to transfer and then do the stenting, you have to try and do that in 90 minutes. So previously they used to have these concepts called door to needle time, door to balloon time. So those are sort of redundant concepts. The important concept now is doing a PCI within 120 minutes, and our targets are to do it in 60 minutes in a PCI center and 90 minutes in a non-PCI center where you have to transfer. All right, so this is what I was trying to basically show you with my hands. So you have a clot, you have a thrombus that is blocking your blood vessel. We put a stent through that block, and then we nicely expand the stent so that the block gets unblocked, basically. So it's a very beautiful concept. I mean, it's very fascinating. And if you've had the chance to see it happening in real life, you'll be mind blown. So you pass the stent and it will nicely open up the block. And now this blood vessel, there was no blood flowing, right? There was very little blood flowing through this blood vessel to the heart. But the moment you put the stent, you have a nice pipe, you have a nice blood vessel for the blood to flow. So there's going to be enough blood flowing into your heart muscle, and your heart muscle is going to get saved. All right. So what happens if you can't do that within 120 minutes? Are you just going to let the patient be? No. So there are other medical managements that are available as well. So if you cannot do the percutaneous intervention within 120 minutes, you can go for something called fibrinolysis, which is also referred to as thrombolysis. So whatever word you prefer, fibrinolysis is a bit more pharmacologically proper term, but thrombolysis is good enough. So what you do is you give a patient a medication. We inject a patient a drug that is going to go and dissolve the clot. So when you have a clot, that drug will go to the clot and it will break up the clot. So, so fibrinolysis is quite important, and it's a widely available thing because PCI is not available everywhere, but fibrinolysis or thrombolysis is available throughout the island. So basically, if you don't have PCI available, you can go for this. And how fast should you do it? 10 minutes, because I mean, there's nothing for you to transfer, right? You do the ECG, you just thrombolyze the patient. You don't have to shift the bed or put the patient to a trolley, put the patient to ambulance. None of that is there. So you should be able to immediately start the treatment. So our target time is 10 minutes. So please keep the targets in mind. 120 minutes to decide between PCI and thrombolysis. If you are doing PCI, within 60 minutes in a PCI center, 90 minutes in a non-PCI center. If you are thrombolizing or fibrinolyzing, 10 minutes. You have to do it within 10 minutes, right? So that is just the time taken for you to put a cannula, get the drug, and to inject it. So, I mean, it should not even take 10 minutes in a proper setting. All right. So, what are the drugs that are available? So, you have many different drugs that are available, such as streptokinase, tenecteplase, and alteplase. Streptokinase used to be the drug of choice in the past. When I started my internship, we used to use streptokinase, but now we have much better drugs because streptokinase has a lot of problems. It can cause severe allergic reactions. It can even cause anaphylaxis. It can cause severe arrhythmias. So, I mean, it's like, one problem after the other. You give streptokinase to save the patient from a STEMI, and then the patient gets a arrhythmia, right? So, those things can happen, and it can also cause bleeding. There are so many patients who end up dying due to intracranial hemorrhages. So streptokinase is quite a dangerous drug. Things have got better now because we have tenecteplase and alteplase. So these two are better drugs because they are fibrin specific. So they go and act only at the clot. Streptokinase, this guy will go and act all over your body. It can sort of try and dissolve clots all over your body. So that can cause bleeding. Tenecteplase and alteplase will specifically act on your plaque. So that will cause less bleeding and less other side effects as well. Tenecteplase is the preferred drug from the two because it tends to be a bit more fibrin specific. So if you have tenecteplase, that would be, I would say, the best drug to use for fibrinolysis. So best treatment is fibrinolysis. Second best would be tenecteplase. So this is for your interest, some differences between alteplase and tenecteplase. So you can see that both of them are not immunogenic. So streptokinase is immunogenic in the sense that it elicits an immune mediated reaction. So it can lead to basically lead to anaphylaxis and severe allergic reactions. So these two are less immunogenic, so the chance of allergic reactions are less. They are more fibrin specific. So alteplase and tenecteplase are fibrin specific. So they are going to act only at the region of your clot. It's not going to act elsewhere. So the advantage of having a fibrin specificity is the fact that it will lead to less amount of bleeding. So complications such as bleeding are going to be less. And you can see that comparing these two, tenecteplase tends to be a bit more superior to alteplase as well. The half-life of tenecteplase is a bit longer than alteplase. It takes about 20 minutes, while alteplase is about 4 to 6 minutes. So this is the dose, so you don't need to know the doses. The doses are given in the manufactured box, and it's usually weight-adjusted dose. So when you are less than 50 kilograms, we give about 30 milligram of tenecteplase. So likewise, depending on the weight, we can adjust the doses. All right, so fibrinolysis is the second option when PCI is not available. Always prefer tenecteplase over streptokinase or at least alteplase because those are the better drugs. All right, now can you thrombolize or can you fibrinolyze everyone? So the answer is no. Again, you have some barriers to fibrinolysis. So there are a group of patients where you can't give fibrinolytic drugs. So there are a group of patients where you can't give tenecteplase or streptokinase. So why is this important to know? Because if you give tenecteplase to any of these patients, they are going to die. Not of the STEMI that they came with, they are going to die because of these complications of bleeding. So make sure before you give any of these thrombolytic agents, make sure that you exclude these contraindications. So how are you going to exclude the contraindications? So how we do that is we are going to basically we are going to look for active life-threatening bleeding. So if the patient is having a severe bleeding, for example, the patient is having a wound from where the patient is bleeding or cut his leg and the patient is bleeding, don't go and thrombolize because the patient is going to get severe bleeding and die. If the patient has had an intracranial hemorrhage, if the patient has had bleeding into the brain, again, don't thrombolize. And this is forever, right? So even if the patient has had an intracranial hemorrhage 10 years back, 20 years back, you can't thrombolize. So you don't have an option of thrombolysis because what happens is in a patient who has had an intracranial hemorrhage, if you go and thrombolize them with the purpose of saving the heart, you're going to cause more bleeding into your brain and the patient is going to die from the bleed. If the patient has had an ischemic stroke within 3 months, so unlike ICH, ischemic stroke only within the last 3 months, because within the last 3 months, the patient's brain tissue is going to be very fragile. And when you thrombolize, it might sort of bleed. So within the 3 months, if there's a stroke, don't thrombolize. If the patient is having known vascular lesions like arteriovenous malformations, because if you thrombolize such patients, they can start bleeding from these malformations. If they have the tumor in the brain, an intracranial neoplasm, again, there can be bleeding into those tumors. Aortic dissection, where the aorta sort of ruptures, the wall ruptures, where you get a very stabbing, tearing type of chest pain that is radiating to the back. Again, bleeding if you thrombolize. If the patient had had any major intraspinal or intracranial surgery, the surgical tissues are very fragile, so don't thrombolize because you can get bleeding. And of course, very high blood pressure. Because when you have very high blood pressure, again, you are at a risk of intracranial hemorrhage. So again, if you have very high blood pressure, you have to reduce the blood pressure before you thrombolize. So you have to bring down the blood pressure to at least 180 by 110. So if you get a patient coming with high blood pressure like 200s, don't thrombolize them. Always quickly reduce their blood pressure by giving a GTN infusion. And only once you get the blood pressure down to 180 by 110, then you go ahead and thrombolize. So I think I used the word intracranial hemorrhage a lot during the last few seconds. The reason for that is the most dreaded complication of thrombolysis. We are all worried about an intracranial hemorrhage when we thrombolize these patients. So make sure that you tick these off when you thrombolize. So as the house officer, you're supposed to ask all these questions and make sure that the patient doesn't have any of this. And if you're unsure about any of this, you might even do a CT scan to exclude these things before thrombolysis. There are some relative contraindications. So if the patient has any of these conditions, it is not that you should never thrombolize, but you should be a bit more careful. So you should think twice and you should weigh the risk and the benefit and then only think about thrombolizing. For example, if the patient is having chronic long-standing poorly controlled hypertension, so I said ischemic stroke within 3 months, absolutely no thrombolysis. More than 3 months, you might have to weigh the risk and the benefit. If there's trauma within 3 weeks, if there's a major surgery within 3 weeks, if there are vascular punctures that are not compressible. So if you have damage to any of your blood vessels and then you thrombolize, you can get bleeding from the blood vessels. But of course, if they are compressible, if you can sort of compress them, then that's fine, because if you compress them, you can stop the bleeding. But if you have a vascular puncture which cannot be compressed, then again, don't thrombolize, because if you start bleeding, you can't stop it. Pregnancy is a relative contraindication as well. And also, if you are using anticoagulants, again, you're at a high risk of bleeding, particularly if your INR is more than 1.7. So these are some relative contraindications to exclude. So what are the features of successful fibrinolysis? Now, after you've done a fibrinolysis, you need to be sure that it has worked. You need to know whether the blood supply to the heart has been fulfilled. So if you have done an angiogram and put a stent, you can actually see your angiogram contrast flow through the block. So that angiogram, in the angiogram, the blood went and got stuck somewhere, right? So the moment you put a stent, you can see the blood going beyond the block. But when you thrombolize a patient, we don't have anything to see that occurring. So how do we know whether it has worked? I mean, just because you give the tenecteplase, we don't know whether the clot got dissolved. So how do we know that the clot got dissolved and now the ischemia has resolved? So first thing is the ischemic chest pain should go off. So the patient who is in chest pain, now the chest pain should get relieved. The next thing is there should be at least a 50% reduction of the ST elevation in 90 minutes. So what you're supposed to do is you thrombolize the patient, then you repeat the ECG in 90 minutes. Now, when you repeat the ECG in 90 minutes, that ST elevation should come down. So let's say you have a ST elevation of 4 millimeters, it should come down to at least 2 millimeters. So it should reduce by at least 50%. All right. So following thrombolysis, don't forget to repeat the ECG. Repeat the ECG in 90 minutes and look for the reduction in the ST elevation. Also, when your myocardium is getting reperfused, you can get some arrhythmias. So know the names of these arrhythmias. The commonest arrhythmia that you get because of reperfusion is sinus bradycardia. The most specific one is accelerated idioventricular rhythm. So following thrombolysis, if you have these things happening, relief of the chest pain, ST segment comes down by more than 50%, or if you get a reperfusion arrhythmia, then you can be very, very happy that you have done the job well, and the patient is now going to survive. If these things are not occurring, that means your thrombolysis has failed. If your thrombolysis has failed, unfortunately, you can't thrombolize again. The only option is a percutaneous intervention. So whether it takes 120 minutes, whether it takes 2 hours, 3 hours, 5 hours, you have to transfer the patient for a percutaneous intervention. So if you can't do it within 120 minutes, you thrombolize. But if the thrombolysis fails, then regardless of the time, if there's failure of thrombolysis, you have to send the patient for a percutaneous intervention. So when we do a percutaneous intervention in a patient where the thrombolysis has failed, we name it rescue PCI, because we are rescuing the patient from dying after the fibrinolysis has failed. So that's called a rescue PCI. Of course, there are some adjunctive medication that you need to give. So these are antiplatelets, including dual antiplatelets such as aspirin and a P2Y12 inhibitors. So there are many different P2Y12 inhibitors available. The most widely available one is clopidogrel, but you have better and more effective drugs now, such as ticagrelor and prasugrel as well. Ticagrelor and prasugrel are actually preferred over clopidogrel if available. And if the patient is undergoing PCI, prasugrel is actually preferred to ticagrelor as well. So please know that following this thrombolysis, you have to continue aspirin with one of these drugs. Commonly in Sri Lanka, we give aspirin and clopidogrel. For how long? For at least 12 months following a stent. Why 12? Why are we so worried when it comes to a stent? Because stents can get blocked. There can be stent thrombosis and there can be stent restenosis. So if you remember the start of the lecture, I was talking about type 4 MI. Type 4 MI is when you get MI following a stenting, either due to thrombosis or stenosis. So to prevent those things from happening, we have to give dual antiplatelets, that is aspirin plus clopidogrel or another drug for at least 12 months. If we have thrombolyzed or fibrinolyzed, the problems of stent thrombosis is not there. So 6 months of dual antiplatelets is enough. There's also a role for anticoagulation as well. So anticoagulation will also prevent the propagation of the thrombus. So we give anticoagulants, as the name suggests, to prevent the coagulation from propagating. So we have different anticoagulants that are available, including unfractionated heparin, enoxaparin, or bivalirudin. We can give these drugs during PCI. And following thrombolysis, we are supposed to continue this anticoagulation for at least 3 to 5 days. So that is another advantage of PCI, because if you go in and stent the patient, you can, discharge the patient even the next day, provided that the patient is okay. But if you thrombolyze using something like streptokinase or tenecteplase, you can't do that. Following the thrombolysis, since it is not as effective as PCI, we have to continue the anticoagulation for at least 5 more days. So the commonest anticoagulation that we use is actually enoxaparin. So for these patients, we continue the enoxaparin for at least 5 days. So these are some of the different antiplatelet drugs that are available if you are interested. So these are the mechanism of actions. So back to your pharmacology days. So you have the cyclooxygenase inhibitors like aspirin. Then you have the P2Y12 inhibitors or the ADP receptor inhibitors. You can have irreversible ones such as clopidogrel and ticlopidine, or you can have reversible ones such as prasugrel and ticagrelor or cangrelor. There are also other antiplatelets that are available but not as commonly used, including the phosphodiesterase inhibitors like dipyridamole or cilostazol, and of course the glycoprotein 2B3A inhibitors such as abciximab, tirofibab. So all of these drugs can be used as antiplatelets, but in practice we usually stick to the type, the first and the second type, which is aspirin and the P2Y12 receptor inhibitors. Okay, so those are the essential drugs that you have to use in these patients with acute coronary syndrome. But in addition to these essential drugs, there are some adjunctive medication that you can use as well. So one is the beta blockers. Now, what do beta blockers do? So if you go back to your physiology, so now you understand why it's important to study pharmacology, physiology properly, because it keeps coming back to you when you practice medicine, right? So you have certain receptors in your body called the beta receptors, right? You have a group of beta receptors in your heart, which are called beta 1 receptors. And those beta 1 receptors, when they get stimulated, it makes your heart beat faster and more strongly. So it makes your heart contract and also beat faster. Beta 2 receptors are mainly located in your airways and your blood vessels. Now, when I mentioned about myocardial infarction at the start, if you paid attention, I was talking about how it can occur due to a mismatch between the demand and the supply. So when your demand goes down and your supply goes up, when your demand goes up and when your supply goes down, there's going to be ischemia. Why? Because the heart is in need of more blood. So the demand is high, but you are not supplying it with enough blood. So your demand is high and your supply is low. So that is why you are getting myocardial infarction. So what are we going to do? We have to try and bring the demand and the supply together. So now they have gone far apart. Demand high, supply low. So what did we do by giving the stenting or the anticoagulation? We increased the supply. So we increased the supply and we brought it close to the demand. Another way we can treat the patient is to bring the demand down. In addition to increasing the supply, we can also bring the demand down. So if we bring the demand down, that will further improve the perfusion of the myocardial tissues. So how do we reduce the myocardial demand? We reduce myocardial demand by slowing the heart. So if the beta 1 receptors are increasing the heart and increasing the demand by increasing the heart rate, increasing the heart contractility, we give beta blockers to slow down the heart, and to reduce the myocardial demand. So it's very easy stuff, guys. So, if you understand it, it's very easy to remember. You don't need to keep cramming this again and again. So just understand it like this and you will remember it for the rest of your career, right? So you give beta, so in addition to increasing the supply, you reduce the demand by giving beta blockers. In addition to that, we have to maintain the patient on high intensity statins. So we can give statins such as atorvastatin at a dose of about 40 to 80 milligrams, or rosuvastatin at a dose of about 20 to 40 milligrams. So why are we doing that? To bring down your lipid levels so that you can prevent the plaque from forming again. And the main role of statins is they stabilize the plaque. Because even though you have a plaque, you have a nice fibrous capsule protecting it, it's all good. So to make sure that you have a stable plaque which doesn't rupture, statins have a very important role. So when we give statins, we have various targets. So our target is to maintain LDL cholesterol. So when I talk about dyslipidemia, I'll be discussing this in detail. But remember, when it comes to interpreting a lipid profile, the main thing is your LDL cholesterol. So our target is to keep the LDL cholesterol as low as possible. So our target in these patients is to keep the LDL cholesterol less than 55 milligrams per deciliter, and we reduce it to at least 50% from the baseline. So let's say a patient had a LDL cholesterol of about 150, we have to bring it down to at least 75, right? And better if you can bring it down to less than 55. So, so those are your lipid targets. There are other medications that help as well, including AC inhibitors, such as enalapril, because AC inhibitors like enalapril will reduce the myocardial remodeling. Because once the myocardial tissue gets damaged, once the myocardial tissue gets ischemic and infarcted, they will undergo remodeling. Now, this remodeling is going to cause some permanent severe changes in your myocardium, and that is what causes significant heart failure. So to basically prevent that from happening, to prevent this myocardial remodeling and heart failure, we can go for drugs like AC inhibitors, which is the common one available for us is enalapril. So how do you manage? So that comes to the end of the management of management of STEMI. So how do you manage the non-STEMI and unstable angina? So if you have ruled out a STEMI, right, the next possibility, if you have ECG changes, is non-STEMI and unstable angina. How do you differentiate between the two? Cardiac biomarkers. If your highly sensitive TROPA is positive, it's non-STEMI. If it is negative, it's unstable angina. So how do we manage these two conditions? So the management of these two conditions are quite similar. You have only very subtle differences. So we go by a risk-based approach. Now, when it comes to non-STEMI, one patient who comes with non-STEMI is quite different to the next person who comes in non-STEMI. So each patient is different. So we go for a risk-based approach. What we do is we classify or we categorize these patients according to the severity of their non-STEMI or the unstable angina. So how we do this is that we have certain scoring systems. So there are various things that we put into the scoring system, various aspects that we look into, and then we get a score. So one of the commonest scores that we use is the gray score. So if you have a very high score, that means you have a very high risk. If you have a low score, that means you have a low risk. So if you have a high risk, then you should go for an early invasive angiogram. But if you have a low risk, then you can do an angiogram later on, and you can just stick to the medical management. So what is the medical management of non-STEMI and unstable angina? It's very easy. So you know the STEMI management, just forget about reperfusion. So in STEMI, we spoke a lot about reperfusion, right? We spoke about PCI and we spoke about thrombolysis. So just forget about those two. And the rest of the management is the non-STEMI and unstable angina management. So it's quite simple. So we don't thrombolize. What we do is we give the rest of the treatment. So we have to go for dual antiplatelet therapy. So dual antiplatelet therapy, again, to remind you, it's aspirin with P2Y12 receptor inhibitor. Clopidogrel is what we usually have when used, but the better ones are prasugrel and ticagrelor. And then anticoagulation. So anticoagulation is a must when it comes to non-STEMI and unstable angina. So you have various drugs available, such as unfractionated heparin, enoxaparin, and fundoparinix. Enoxaparin is what we use because it's very freely available in our setting, and we don't need to monitor the APTT. Because if you give unfractionated heparin, we have to keep monitoring the APTT 6 hourly. Enoxaparin, you can just give it. It's given as a BD dose or twice a day dose. So the only difference in the management between non-STEMI and unstable angina is actually the duration of the enoxaparin. That is it. Rest of the management is exactly the same. So the only difference is in unstable angina, we give enoxaparin for 48 hours. While when it comes to non-STEMI, we give enoxaparin for 72 hours. Rest of the management is exactly the same. So remember, in STEMI, we gave enoxaparin for 5 days. Non-STEMI, we are going to give it for 72 hours or 3 days. Unstable angina, we are going to give it for 48 hours or 2 days. So the duration of the enoxaparin is different between these 3 types. Rest of the treatment is the same. We have to reduce the myocardial demand by giving beta blockers. We have to stabilize the plaque by giving statins, and we have to reduce the remodeling by giving AC inhibitors. So now when a patient comes with a myocardial infarction, it doesn't give you a guarantee that he's not going to come again with it. I mean, we get enough patients who come with one myocardial infarction after the other. We discharge them after treating them, and then the next month they come to us again. Again, we treat them, 2 months later they come again. So that is because the secondary prevention is not done right. So secondary prevention is basically when you prevent a vascular event from happening again. So basically, when you get a patient with myocardial infarction, you have to make sure that they don't get it again. So first thing to prevent that is basically lifestyle modification. So you have to ask the patient to stop smoking, because smoking is one of the worst enemies of the heart, can cause blocking of the blood vessels. Dietary changes. So you should ask the patient to eat healthy, reduce the amount of fat, reduce the amount of lipid in the diet, go for more fruits and vegetables, go for more proteins. Ask them to lose weight if they are overweight, and regular exercise. So what the guidelines recommend now is that you need at least 150 minutes of moderate intensity exercise per week. That is about 30 minutes of moderate intensity exercise a day for 5 days. And along with that, you need 2 days of resistance exercises like weightlifting as well. So you have to promote all these in your patients. In addition to that, again, a reminder to continue the medication. So dual antiplatelets, we go for 12 months. After 12 months, we continue the aspirin lifelong. So you give aspirin and clopidogrel for 12 months. Then after 12 months, you continue the aspirin. So you will never stop the aspirin. Any patient who you have managed for a myocardial infarction, aspirin is lifelong. Never stop it, right? So till the patient dies, you have to give the aspirin. And of course, continue your beta blockers, statins, and AC inhibitors. Now, we were talking about the ideal management, but no matter how well you manage patients, some of these patients are going to get myocardial injury. So you have to also think of methods to improve their functionality following the myocardial injury. So that requires rehabilitation. So you can have various rehabilitation programs, including physical, psychological, and educational support. So this is how you manage a myocardial infarction overall. Finally, the management of complications. So these will be dealt separately under each of these topics. But you should know that these are the 3 major complications of myocardial infarction. One is heart failure, where your heart is not pumping enough blood. So you are going to have low blood pressure. Your body is going to get flooded with fluid. You're going to get edema. You're going to get congested lungs. So if your blood pressure is low, you might have to go for inotropes. If you get fluid overload, you might have to go for diuretics. There are various drugs with mortality benefit in heart failure: AC inhibitors, beta blockers, spironolactone, and SGLT2 inhibitors. So I'll be talking about these in detail on the topic of heart failure, but please realize that heart failure is what happens if you don't do what I said in the last 1.5 hours, right? So if you don't treat the patient properly, there's going to be irreversible injury and death of the myocardial tissues, and the patient is going to go into heart failure. In addition to that, they can get rhythm abnormalities, particularly if your right coronary artery is blocked. There can be blockage of the blood supply to your conducting system. So you can get changes in the rhythm of your heart. So you can get arrhythmias, which you will have to manage with antiarrhythmics. You can also get mechanical complications depending on which part of the heart is infarcted. For example, if there's infarction of the papillary tissues of the heart, your mitral valve is going to get damaged. So you can get an acute mitral regurgitation. So sometimes myocardial infarction patients can end up with an acute mitral regurgitation. This is why if you're patients with myocardial infarction, right? I mean, after managing a patient with myocardial infarction, if they are still unstable and if they have low blood pressure with heart failure, which is not responsive, always think about a mitral regurgitation. So always it's important to auscultate for the murmurs. So damage to the papillary muscles will lead to acute mitral valve regurgitation. Or you can get a septal rupture. So you can get an acute ventricular septal defect. I mean, all of you have heard about VSDs, right? So VSDs are one of the most common congenital heart abnormalities. But because of a myocardial infarction, you can get an acquired ventricular septal defect. Or your entire myocardium can rupture and you can get a hemopericardium. So these are some of the mechanical complications, and you will have to treat these patients with surgery. So if you get a mitral valve regurgitation, you will have to go for a mitral valve replacement or a mitral valve repair. If you get a ventricular septal defect, you will have to close the septum. And if you get a free wall rupture, you have to repair that. So these are the main complications to watch out for. So that comes to the end of the treatment and the end of the lecture. Another important thing which I left till the end is a common question that they ask is which of these treatments have survival benefit? Now, I spoke of a lot of treatment, right? I spoke about pain relief. I talked about diuretics. I talked about morphine, nitrates, antiplatelets, enoxaparin, thrombolysis, stenting. So when you talk about treatment in medicine, some of these treatment will allow the patient to live longer or will protect the patient from death. Those are the essential medication that we have to give the patient. Those are basically medication with survival benefit. Those are medication which we give to protect the patient from death. Or you can give drugs for symptomatic benefit. So these drugs will not really protect from death, but they will basically reduce the harmful symptoms that the patient is having. For example, if the patient is under severe pain, you can give pain relief, right? So that is not going to prolong the survival, but it's going to give a symptomatic benefit. But things like stenting, that is going to allow your patient to survive. So all these treatments can be divided into drugs with survival benefit and drugs with symptomatic benefit. So the drugs with survival benefit include your percutaneous intervention or stenting. It includes your thrombolysis, that is tenecteplase, alteplase, streptokinase. It includes your antiplatelets, your statins, as well as your adjunctive medication like your anticoagulants such as enoxaparin, right? As well as beta blockers and ACE inhibitors. So percutaneous intervention, thrombolysis, antiplatelets, statins, beta blockers, ACE inhibitors, they are all drugs with survival benefit. Drugs with symptomatic benefit are the drugs that we give for pain relief. That is basically your morphine and the nitrates. And if the patient has heart failure, you can give diuretics. Those also you are giving to reduce the symptoms of shortness of breath. So diuretics, morphine, nitrates, they only have symptomatic benefit. Rest of the drugs will have survival benefit. So that comes to the end of the lecture, and I hope you learned about acute coronary syndrome. So next, what we are going to do is we are going to discuss some questions. So it's going to be like a poll, so you don't have to be scared. It's not an exam, right? So just feel free, just answer on the poll. I'll be putting it up now. Just answer what you think is correct, and then we'll discuss those answers, right? So we'll discuss 10 questions. Do you have any questions before we get into that? Any questions that you want to ask me? Don't feel shy, just clear your doubts, because as I said before, you're investing your time by joining this program. So make sure that you take the best use of it. All right, so I take it that you've understood everything properly. So let's go to some questions. So some of these questions are from past papers and some have been designed by me. So we'll just go through them. All right, so there is a, so 1 second, I'll just end the poll for now. All right, so sorry, there's one question about door to balloon time. So door to balloon time basically means the time that you should spend from the time the patient enters into the hospital to the time the coronary angiogram is done, right? So that should be around 60 minutes, right? So you should try and do that within 60 minutes. So that is basically from the time the patient enters into the hospital to the time you do the angiogram. All right. Door to needle time is from the time the patient enters the hospital to the time that you thrombolize, which is around 30 minutes. But a better way to define these times are from the time you diagnose it to thrombolizing. So from the time you diagnose it to thrombolizing, that should be maximum of 10 minutes. Door to needle is from the time the patient enters into the hospital to the time they are thrombolized. So that would be about 30 minutes. So I hope that answered your question. Any other questions, please? You can ask me now. All right, so shall we then do the questions? So I'm going to put up a poll, so I hope you can see it. All right, so can you see the poll? Hello?
Yes, sir.
All right, so can you all answer? So I'm going to give you 1 minute to answer, right? Or 2 minutes. So we start with the first question, right? We'll go through the entire thing and then we'll go through the answers. So I'll give you 10 minutes to answer these 10 questions, all right? It's you can see it on your screen, right? And you can choose the options, right? Okay, so quite a few of you have answered. So let's discuss. So don't worry. I mean, some of these questions I purposely put to sort of discuss around it, to discuss some more theory around it. So it's okay if you couldn't answer some, right? So all right. So let's basically go through the questions, right? So the first one was a patient presents within 30 minutes of an onset of chest pain to a hospital in suburbs of Colombo, so probably somewhere like Pandura, right? His ECG has shown a STEMI. So primary PCI center is only 60 minutes away. However, there is an expected delay of 45 minutes in transport due to a protest on the uh, road to the PCI center. So basically what they're saying is usually it will take about 60 minutes for the patient to be uh, transferred. However, there is also going to be a delay of 45 minutes in the transport due to the protest, right? So what are we going to do? So some of you have said to give dual antiplatelets, loading doses and observe, treat with enoxaparin, treat with IV morphine and oxygen. So now what they have meant here is, so what I was trying to tell you here is basically the concept about the 120 minutes, right? So basically, if you can do the PCI within 120 minutes, you should always go for the PCI, right? This is not 120 minutes from the time the patient comes to you, right? It's 120 minutes from the time that you diagnose the STEMI. So basically the 30 minutes of the chest pain is not included in the 120 minutes. So regardless of the time the patient comes to you, if you can arrange the PCI within 120 minutes, then that is what you should do. All right. So since if the total time, if you can arrange it within 120 minutes, then you should go for a PCI despite the delay, because if you can still transfer and do the PCI within 120 minutes, that would mean that it's okay. But if you think that it's going to go beyond 120 minutes, then the next thing is to thrombolize with tenecteplase. So dual antiplatelets is definitely should be given. So that answer is correct. But just observing after giving dual antiplatelet, it's not going to be good enough, right? Because you would have to do something more. It's a STEMI, so you have to reperfuse either by thrombolysis or by a PCI. So just observing after dual antiplatelets is not good enough. Transfer the patient despite the possible delay. So if you can transfer and get the PCI done within 120 minutes, yes, that is actually one of the best options, right? So if you can do it within 120 minutes. Treat with enoxaparin, no, again, because it's a STEMI, so you have to first of all reperfuse. Only after reperfusing with a PCI or a thrombolysis, then you can go for enoxaparin. Treating with IV morphine and oxygen, that might be symptomatically beneficial, but survival-wise, it's not going to do much. So treat with tenecteplase. So those are the options that you have. If you can do it, the total time is 120 minutes, PCI, if not tenecteplase. So those would be the answers. All right. So second one, a 68-year-old man is admitted to the medical casualty with a chest pain for 1 hour. On initial assessment, he's in pain, heart rate is 40 and blood pressure is low. Which of the coronary artery is most likely to be affected? So now you need to think out of the box to come to this answer. So patient is having a heart rate of 40, right? So patient is having a heart rate of 40. What does that tell you? It tells you that the conducting system of the heart has been affected. So you have a conducting system of the heart consisting of the sinoatrial nodes, the AV nodes, and all these other conductive tissues. So if there's ischemia to the conductive tissues, you can get a bradycardia. So this patient is having a heart rate of 40 because there's ischemia to the conductive tissues. So as I mentioned in the lecture, which artery supplies the conducting tissues? The right coronary artery. So when you have a block in the right coronary artery, the conducting system of the heart is going to get affected. And as a result, you're going to have bradycardia. So the clue in this question is the heart rate of 40. So this is how you answer SBS. You have to pick up the clues and then you have to go behind the clues. Now in the first question, the important thing was the time, whether that 120 was being met or not. Second question is the heart rate of 40. Now you know heart rate of 40 means conductive system has got affected. So it's a block in the artery supplying the conductive system. And what is that? Right coronary artery. So the answer should be right coronary artery. And some of you have got that correct. All right. So next we have a 60-year-old patient with acute coronary syndrome who's on aspirin and atorvastatin who has presented with chest pain. Thrombolytic therapy has been given and the echo is showing 35% EF. What are the drugs that can be added to her with prognostic benefit? So actually, this would be dealt again in the topic of heart failure. So prognostic benefit is just another name for survival benefit, right? So again, when you go to the exam, you should be familiar with these synonyms, right? Because we study as survival benefit, symptomatic benefit. So why I put this question is, you should know the synonyms to those terms as well. That's very important. So prognostic benefit is survival benefit. So what are the drugs with survival benefit? Those would be the PCI, thrombolysis, AC inhibitors, beta blockers, and the mineralocorticoid receptor antagonists. So diuretics don't have a prognostic benefit, and pain relief like nitrates and morphine also doesn't have prognostic benefit. So furosemide is a diuretic which doesn't have prognostic benefit, so that goes out. There's furosemide here as well, so that goes out. ISMN is a nitrate, so nitrates only have symptomatic benefit or pain relief, so that doesn't have a prognostic benefit, so that is out. Enarapil is an AC inhibitor, metoprolol is a beta blocker, spironolactone is a mineralocorticoid receptor antagonist. So like most of you have marked, that is the correct answer. The last one is not correct because digoxin again is not a commonly used drug for myocardial infarction, but if at all, it does not have a prognostic benefit. So sometimes it's a bit easier to remember the drugs that don't have a prognostic benefit. So pain relief, morphine, nitrates, no prognostic benefit. Diuretics, furosemide, no prognostic benefit. Digoxin, no prognostic benefit. Thrombolysis, PCI, antiplatelets, statins, anticoagulants, beta blockers, AC inhibitors, spironolactone, they have prognostic benefit. So this is again a very common question. You can get this for heart failure as well as you can get this for acute coronary syndrome. So you can get it as drugs with mortality benefit in patients with heart failure and drugs with mortality benefit in patients with acute coronary syndrome. All right. So next one. 45-year-old male who is on treatment for acute coronary syndrome developed an acute onset breathlessness after 3 days. So now what are we talking about? Now try to figure out which section. So acute coronary syndrome who has been treated, now problem is coming after 3 days. So we are dealing with the complications of acute coronary syndrome. So what are the three main complications? Heart failure, right? Heart failure, arrhythmias, and the mechanical complications like mitral regurgitation, septal wall rupture, and VSD, right? So which of these three are we dealing with? So patient has come with an acute onset breathlessness. Now, acute onset breathlessness can occur in all three, right? It can occur in heart failure, it can occur in mechanical complications, and rarely even due to arrhythmias. Heart rate is 130, blood pressure is 88/60. Again, you can't differentiate between the three. Patient has diffuse inspiratory crackers. Now, that tells you that you're either dealing with a heart failure or you are dealing with a mechanical complication. Because what do you understand by inspiratory crackers? Inspiratory crackers tell you that your lungs are flooded with fluid. Why will your lungs be flooded with fluid? Either because you have heart failure or because you have a mechanical complication. Arrhythmias usually don't cause crackers. So now we know that we are dealing with either heart failure or we are dealing with a mechanical complication. Then the final clue is the systolic murmur, which was heard on the precordial. Now, systolic murmur will not be heard in heart failure. It will be heard due to mechanical complications. Now, the systolic murmur can either be a ventricular septal defect, where you get a pan-systolic murmur, which I'll be talking about the different murmurs in further lectures. So, ventricular septal defect will cause a pan-systolic murmur, and acute mitral regurgitation due to the papillary muscle rupture. So this is what I concluded the lecture with. Papillary muscle rupture can cause an acute mitral regurgitation. That can also cause a pansystolic murmur. So since the option of ventricular septal defect is not there, the answer to this question is papillary muscle rupture, which has caused the flooding of the lungs with fluid due to the acute mitral regurgitation and the systolic murmur. Left ventricular failure alone will not cause a murmur. So acute pericarditis will not present like this. It presents with sort of a pricking type of a chest pain. Cardiac tamponade will come with shock with absent heart sounds. So this patient had heart sounds. I mean, it's because you had heart sounds that you heard the murmur. If it's a cardiac tamponade, you won't hear any murmur. It will be very soft heart sounds. Pulmonary embolism again won't produce a murmur, and it won't produce fluid in the lungs because it's sort of ischemia to the lungs, right? So the answer here is a papillary muscle rupture, and that has caused an acute mitral regurgitation, which is why you are getting systolic murmur with lungs getting filled with fluids. All right, so another one is a 32-year-old female diagnosed with SLE 2 years back, presented with acute chest pain, which was diffused and increased on lying down. Rest of the cardiovascular system was unremarkable. ECG shows ST elevation. Now, this is again a very, very interesting question because now I mentioned that when you take a patient with acute coronary syndrome, how you diagnose a patient with acute coronary syndrome is only by the history. So this I put to test whether you can diagnose an acute coronary syndrome with an history. So acute coronary syndrome, what does the history tell you? Tightening, pressing side type of a chest pain, which radiates to your jaw, which gets worse with exertion, right? It doesn't increase on lying down. So increase on lying down is not a feature of acute STEMI. So acute STEMI is out because that doesn't increase on lying down. So the chest pains that increase on lying down or the chest pains that change with position are due to inflammation of the serosal membrane. So that is either due to inflammation of the pericardium causing pericarditis, or it can be due to inflammation of the pleura causing pleuritis causing pleural effusion. So since this is sort of an acute chest pain, which is increase on lying down. So remember, any chest pain that gets worse when you lie down, you have to think about pericarditis. So remember, STEMI or ST elevation myocardial infarction is not the only condition where you can get a ST elevation. You can get it in so many other conditions, including STEMIc, myocarditis. You can get it due to severe hypoperfusion as well. And you can get it in certain other syndromes like Brugada syndrome as well. So basically what you have to remember is that every time you get ST elevation MI, it's not just, sorry, every time you see an ST elevation on the ECG, it's not always a STEMI. There can be other causes as well. So if it's a pain that is changing with position, it's due to acute pericarditis. And another clue for this answer is the fact that the patient has SLE, because SLE can cause pericarditis. So next one is a 60-year-old patient with diabetes and hypertension, poorly controlled for 10 years. And now he's coming with a central tightening chest pain associated with sweating. So central tightening chest pain associated with sweating. So, I mean, that is a typical chest pain. That is how a patient with acute coronary syndrome is coming. Now the ECG is normal. So what do? So very good. Most of you have chosen the correct answer. Repeat ECG and the highly sensitive troponin I. Because I said during acute coronary syndrome, your heart is changing. It's getting ischemic. So your ECG, it's also going to change. Your troponins are going to change. So just because you get a single negative ECG or a troponin, that doesn't exclude acute coronary syndrome. Keep on repeating it to see whether there are changes. So the next step should be to repeat the ECG and the highly sensitive troponin. Sublingual GTN is, I mean, it's fair enough. I mean, to give some pain relief. But the more important thing is to repeat the ECG and the troponin I. Now, this is an important thing when it comes to SBS, because always when it comes to SBS, you are going to end up with about 2 or 3 answers that are quite, I mean, correct. Technically, they are correct. So if it's a true false, you can mark many answers. But if it's an SBS, you have to choose one. So here, out of the 2, sublingual GTN and repeat ECG tropi, repeat ECG tropi is the important one because you need to come for the diagnosis. Giving GTN is only going to resolve the pain. It won't really tell you what's going on, right? So the best answer is to repeat the ECG to look for dynamic changes. and to see the troponin I. All right, so what is the likely culprit artery who has a ST elevation in V1 to V4? So most of you have chosen the correct answer again. So V1 to V4 is an anterior STEMI due to involvement of the left anterior descending artery. If it is the left circumflex artery, it will be 1 AVL and V5, V6, giving rise to a lateral ST elevation. If it is the right coronary artery, it will be 2, 3, and AVF, showing that there's an inferior STEMI. If it's the left main coronary artery, then both the left anterior descending artery and the left circumflex artery is involved. So basically, you will have V1 and V1 to V4 due to left anterior descending artery, and you can have 1 AVL, V5, V6 due to left circumflex artery. So if it's a left main coronary artery, you will get ST elevation in 1 AVL, V1 to V6. So you get a combination of the left anterior descending artery and the left circumflex artery. So the correct answer here is the left anterior descending artery. So within how many minutes should you thrombolize a patient once you have diagnosed a STEMI? So that is again an important thing. So as I mentioned before, the important concept now is that we take the time from diagnosing STEMI to thrombolysis. So that has to be done within 10 minutes. The student asked, what is the door to balloon time? So door to balloon time is the time from when the patient comes to the hospital to thrombolysis. So door to needle time should be around 30 minutes, right? Door to needle time should be about 30 minutes. From the time the patient enters to doing the percutaneous intervention, that is door to balloon time. So door to balloon time is about 60 minutes. Door to needle time is 30 minutes. But from the time you diagnose to when you actually thrombolize, that should be 10 minutes. And that is a better way of evaluating because, I mean, after the patient walks in, they might go to somewhere else, they might get triage. So there are a lot of other things that come into play. But once you diagnose a STEMI, there's no excuse. You have to treat it. So once you diagnose STEMI, you have to thrombolize within 10 minutes. So good. Most of you have again chosen the correct answer. So 70-year-old gentleman is found to have an ECG showing ST segment depression in 2, 3, and AVF that are dynamic with a positive trop pi. So what is the diagnosis here? Can someone put the diagnosis here? Can someone say it or put it on the chat? So this is an acute coronary syndrome. Are we dealing with a STEMI, a non-STEMI, or an unstable angina? Any answers? Yeah, very good. So we are dealing with a non-STEMI. Because the patient doesn't have an ST elevation, so it has to be either a non-STEMI or an unstable angina because there are dynamic ECG changes. How do you differentiate? You look at the troponin I. Troponin I positive is non-STEMI, negative would have been unstable angina. So how do you manage non-STEMI? You do not thrombolize, right? So thrombolysis is only for STEMI. So aspirin, tropic, stavin, then thrombolysis is wrong because thrombolysis is only for STEMI. Thrombolize then aspirin, pravastatin, again wrong because you don't thrombolize a non-STEMI. So what do? We give stat doses, aspirin 300, propy 300, statin 40 to 80, and then we treat with enoxaparin. How many days of enoxaparin for non-STEMI? Can someone answer again?
72 hours.
Yeah, very good. So 72 hours. If it was unstable angina, 48 hours. So the answer here is aspirin, propy, statin, followed by enoxaparin. So first two answers are wrong. Those are the treatments for STEMI, and then nitrates and morphine, although technically they can be used in the treatment, that is not the best answer here. So remember, single best answer doesn't tell you to choose the correct answer. It tells you to choose the best answer. So from these 5, the best answer is aspirin, propy, statin, and enoxa. So people who have answered nitrates, I mean, that is a correct answer because you will give nitrates to this patient. But the best is to go for the stat doses and enoxaparin for 72 hours. All right, last question. 65-year-old smoker with diabetes mellitus recently managed for an ischemic stroke 1 month back. He defaulted treatment and is not now presenting with a tightening type chest pain and is found to have ST elevation in 1 AVL and V1 to V6. So we are dealing with a STEMI. Which artery is involved? So 1 AVL, V1 to V6. So that means the left main coronary artery is involved. So we have a left main coronary artery block. Nearest PCI center is 2 hours away. So what are we going to do? So most of you have thrombolized with tenecteplase. Some have transferred for PCI, some have started enoxaparin, some are managed with nitrates and morphine. Luckily, no one has just observed. So this is a STEMI, right? So this is a STEMI. You can't just observe. So good. STEMI, you need to do one of the two. You have to either thrombolize or you have to do a PCI. There's no other alternative, right? So managing pain with nitrates and morphine, yes, I agree with your answer, but that is not the best answer because you have to choose a reperfusion strategy. Enoxaparin, I agree, but again, not the best because this is a STEMI. We have to either thrombolize or go for a PCI. Now the question is, are we going to go for a PCI or are we going to go for thrombolysis? So what do we see? The time. So we see whether 120 minutes. So now the PCI center is 2 hours away. So by the time you transfer, it's going to take more than 2 hours. So the patient cannot be sent for a for a PCI or for stenting within 2 hours. So then what is the next step? Thrombolize with tenecteplase. So most of you have chosen that. Unfortunately, that's not the correct answer. Why is that? Can someone tell? So why is thrombolysis with tenecteplase not the correct answer? So I mean, you can't send the patient to the PCI center in 2 hours because it's more than 2 hours away, right? So the next best option is to thrombolize. Yes, exactly. So I said before thrombolysis, always exclude the absolute and relative contraindication. So this patient is having an absolute contraindication for thrombolysis. Patient has had an ischemic stroke 1 month back. So if you thrombolize this patient, patient is going to get an intracranial hemorrhage and patient can even die because of the intracranial hemorrhage. So before thrombolysis, guys, always exclude the contraindications. Make sure that you have excluded the contraindications and then thrombolize, right? So since you can't thrombolize, the only option you have is PCI. So whether it's going to take 2 hours, 3 hours, 4 hours, 6 hours, there's nothing you can do about it because you don't have the option of thrombolysis now. So you have to transfer the patient to PCI regardless of the type. So the correct answer is transfer for PCI, and well done for the person who chose that answer. So there's a question in question 9. If it says ST elevation, what would be the answer? So if they say ST elevation, can you guys put the answers? How do you manage an ST elevation? 2-3 AVF with ST elevation, that is a inferior STEMI, right? Inferior STEMI due to block of the right coronary artery. So what would be the answer? We have to, best answer is to go for a percutaneous intervention, but percutaneous intervention is not given here. Then the next best answer is thrombolize. So do you give stat doses and then thrombolize, or do you thrombolize and then give stat doses? Yes, so that answer is correct. The answer is A. You should always give the stat doses, aspirin 300, clopid 300, statin 40 to 80, and then you thrombolize. For every patient, you give the stat doses, and then finally you thrombolize. All right, so any more questions? Okay, so I hope you understood that about what I said. So this is how you should study. Remember study the core concepts. I mean, you don't need to go to depths of theory, but study the core concepts, and then you should put then you should do questions and study around the questions, because when you study around the questions, that's when you really start understanding and when you become exam oriented. Because for you to pass the exam, you have to be exam oriented and you have to do a lot of questions. But you can't just go and do questions without knowing theory, right? So understand the core concepts and then go behind these questions. And we'll be doing a lot of more questions in the future lectures. So we'll be doing a few more theory lectures. I'll be doing a lecture on rheumatoid arthritis next. So after that, we'll be doing paper classes where we'll be discussing questions, and that's where it really comes into play. But make sure that your theory is strong, and then your questions will be easy. All right, so before we end, there are some questions. So what are the situations we do rescue PCI? Yes. So after thrombolysis, after you have given a thrombolysis, you have to see whether it has worked. There should be resolution of chest pain. The ST segment should come down by more than 50%, or there should be reperfusion arrhythmias. Reperfusion arrhythmias are things like accelerated idioventricular rhythm or a sinus bradycardia. So if those things are met, then you have a successful thrombolysis. If none of those features are met, that means you have a failed thrombolysis. So when you have failed thrombolysis, when you have persistent chest pain, when you have persistent ST elevation, or when you don't have any reperfusion arrhythmias, that is when we send the patient for a rescue PCI. So when it comes to rescue PCI, we don't have time limits. We have to just transfer the patient for a rescue PCI. Yes, I think the answer was given before me also. So when thrombolysis fails, yeah. So any more questions? All right. So we'll be uploading this lecture on YouTube as well. So you can send your questions to us if you have any questions. So stay in touch. Stay in touch with the WhatsApp group and on other social media as well. We'll be updating you. So my next class is going to be about rheumatoid arthritis and osteoarthritis. Please join if you are free. And we'll be doing some paper classes also afterwards. So I hope you enjoyed today's lecture. I hope you learned something. So thank you for joining. Good night.